everybody. Can everyone hear me okay? Thumbs up? Okay, great. Why don't we go ahead and get started with some intros. And Katie, would you like to start for us?
Sure. I'm Katie Chasson-Downs, clinical therapist here at WVU Medicine in Morgantown.
Perfect. Thank you. Aaron Medina, would you like to introduce yourself?
Yes, I'm Aaron Medina. I'm a lead clinician with the United Summit Center.
Perfect. Thank you for joining. And Jeremy Hirschler, would you like to introduce yourself?
Hello, I'm Jeremy Hirschler, addiction psychiatrist. I usually work at the Lakewood Center. I'm over at Chestnut Ridge Center today. Thank you.
Perfect. Thank you. And Tony, would you like to introduce yourself?
Sure. I'm Tony DiGiacchio, family nurse practitioner at WVU Morgantown.
Perfect. Thank you. And Douglas?
Douglas Harvey, case manager for WVU Medicine. Perfect.
Thank you. And I believe it's Hunter Keister with Trinity Family Healthcare.
That is correct.
All right, perfect. Thank you for joining. And Cheryl? Cheryl Harmon, if you're unable to unmute or anything, you can feel free to chat as well. And Megan Toscano?
Hi, I'm Megan Toscano, the project assistant for the MAT expansion grant.
Perfect, thank you. And Sheena?
Hi, I'm Sheena Sayers, the program manager for the MAT expansion.
Great, thank you. And we have a username of SJM0069. All right, you can also chat in as well later if you'd like. And Jeremy Sagan?
Hello, it's Jeremy from Northwood.
Perfect, thank you. And Mega, would you like to introduce yourself?
Hi, this is Mega, project assistant for MAT expansion.
Thank you. And I believe that's Andrew Danko. Would you like to introduce yourself?
Yep, I'm Andrew Danko, the program coordinator for the MAT expansion at WVU.
Perfect, thank you. And Amy Lively.
Hi, I'm Amy Lively, care manager with New River Health Association.
Perfect, thank you. And Laura Simmons. Oh, we got a chat from Laura with Minnie Hamilton, case manager. Perfect, thank you. And Cheryl Harmon chatted in as well, case coordinator for WVU Physicians of Charleston. Perfect, thanks for joining. And let's see, we have Angela. You can go ahead and chat as well if you can. And we have Adina Bao.
Hey, I'm Dina. WVU Charleston Division.
Perfect, thank you. And Sherry, would you like to chat or introduce yourself? Sorry. Oh, you might be muted. Okay.
Sherry Dale, United Summit Center therapist.
All right, perfect. Thank you so much for joining. And Tony, anytime you would like, I can pull up your didactic for you. We don't have a case in today, but we still do encourage everyone to submit any cases that you'd like. I know everything's been sort of crazy with COVID going on, but we would love a case for future sessions as well. But we can jump right into your didactic whenever you're ready.
Okay, bring it up.
All right. Sorry about that. Let's see. Are you able to see that? I think
yeah, I can see it. It's not in. There you go.
Okay, perfect. And just let me know when you'd like me to advance the slides for you.
Okay, sounds good. So I'm going to talk to everybody today about my assignment was best practices, and considering that's a pretty wide swath of topic, this has been modified to be best practices in oral fluid drug testing, specifically related to the situation we find ourselves in now with the COVID pandemic. So next slide, please. So I just want to let everybody know that I have no commercial financial interest in anything to disclose, including relationship at all financially to any of the drug testing manufacturers, listing specific name brand producers during the presentation, but I have no financial interest whatsoever in those. Next slide. So today we're just going to compare some sample matrices for presumptive drug testing, look at the reliability of different oral fluid testing for drugs of abuse, and then check in with some compliance billing and coding issues related specifically to oral fluid drug test in office-based MAT programs. Next slide. So certainly we've all faced a big impact on the delivery of the care that we provide across certainly every service line across the country, probably across the world. And addiction treatment hasn't been excluded from these changes. We've suddenly been placed in a position where the risk of patients merely being in the same room with us or others has dramatically increased. So the risk-benefit ratio related to the care we've traditionally provided has changed quite a bit. So it's forced us to look at rapid cycle change in healthcare delivery. We've gotten regulatory requirements loosened significantly related to telehealth and a lot of things in our state, specifically related to drug testing and therapy and other things that traditionally in office-based MAT programs we'd have to adhere to. A lot of those regulations have been loosened, but it's all it's created uncertainty. And if we're doing things in the best possible way, and when you're in a space of uncertainty, it also allows you to innovate and try different things. So in telecode here at WVU for social distancing in the past month, or more than a month, we've changed things dramatically. Telehealth visits themselves with providers and patients, I think we adapted pretty well, probably like everybody else. Having visits by internet, by distance, thank goodness for technology that we have available today, really isn't that difficult. And certainly psychiatry has been doing telemedicine for probably longer than any other specialty. So that adjustment hasn't been seemingly difficult at all. I know the first couple weeks that we transitioned into this modality, I attended several webinars, national webinars about how to deliver addiction treatment by distance. And invariably, every single webinar had at least one person asking about how do you do urine drug screens in a distance modality. So kind of dove into, I'm by no means an expert in this, but after that, and I had the same question, how do you do that effectively when you're not in the same space as patients? Looked into some concepts around that. And, obviously you can do the telehealth visits and bring patients in randomly to do drug screening. We've kind of evolved to more of a high-risk suspicion parameter. But suspicion can be pretty, well, it's subjective. It's completely subjective. And I wondered if there was a way to objectively put some measurements into what looks like suspicion that you would actually bring a patient in, expose your staff, expose the patients to other people related to COVID. Next slide. So obviously urine drug screening in office-based MAT is important. It's important for patient accountability and structure. It's important for provider accountability to make sure that the treatment plan that we have implemented is effective and it's serving the patient appropriately and helping them get well. And then there's a patient safety element. And as I mentioned, bringing patients into the office does increase COVID exposure risk, both to staff and to the patient. So are there alternative solutions that could allow continuing drug screening, but at a lower COVID exposure risk? Next slide. So there are a number of matrices for testing for drugs of abuse. We're all familiar with urine. That's the gold standard that's been utilized the longest. There's also blood, and we've probably all experienced that when a patient couldn't give a sample of urine. We've drawn blood. Alcohol, you can do breathalyzers. There is oral fluid or saliva. There's also hair and sweat and fingernail clippings for antepartum or postpartum mothers and couplets. There's amniotic fluid and breast milk and meconium of the newborn. And then more invasive or postmortem specimens can be pulled from vitreous humor, bone, bone marrow, liver, or the brain. Next slide. Just in general, the detection time for these different matrices range from minutes to hours, and that's blood and breathalyzers. Oral fluid does result in a shorter window of time that you could detect recent use, more so than urine, but then the window of detection closes much sooner than urine. And then sweat and hair are for longer term evaluations of use. Next slide. So in this distance world that we're living in, random drug screenings for telecoat could include the goals, or should include the goals of a test that we could use the information rapidly at the point of care. We would know either during med management visits or visits with patients, or before those, immediately before those visits, what their screen looks like, just like we do when we see patients in person. It would be portable because we want it to be easily received by the patient wherever they happen to be, or the patient should be able to pick it up if needed, but it shouldn't be too burdensome and encumber a patient as far as needing equipment at home, like analyzers. It also should have a low biohazard risk because you wouldn't want someone at their distant site being exposed to biohazard that's too excessive. Also, ideally, in a telecoat random drug screen model, there would be low tampering risk, meaning you could visually see the patient give the specimen while you're engaged online. And then obviously you want whatever you use to be reliable and relevant. And then for sustainability, it should be cost effective. Next slide. So this might be a little hard to see, but this is really a great tool. It's from ASAM's appropriate use of drug testing in clinical addiction medicine. That was a consensus statement put out by them in 2017. That was looking at the appropriate of drug testing, but it really does dive into every single different matrix you can use, or every different type of specimen that you can use in this setting. And, you know, as you see here, there are different variables that they looked at. And from the slide that I just reviewed, if you look at this chart and consider availability of point of care testing that's non-obtrusive, it's not easy to tamper with, and it's relevant, the one that does stand out is oral fluid. However, as I already mentioned, the window of detection is shorter in oral fluid, shorter than urine, but the inconvenience or intrusiveness of collection is much lower for oral fluid than it is for urine, and there's less chance of tampering. Next slide. So to be able to do a point of care test that's observable during an online visit, really the only feasible matrix would be saliva, oral fluid. Next slide. But the question is it reliable to use oral fluid? And it's not new. It's not a new matrix. It's been evaluated for years, probably a decade or more. But there have been advancements in the accuracy and reliability of these tests, and there has been evidence that other institutions have adopted belief in the reliability of this testing matrix. Specifically, SAMHSA came out just in October of 2019, so less than a year ago, allowing oral testing to be added to urine testing for the guidelines for federal workplace drug testing programs. Up until that point, since the guidelines have been enacted, which was in 1988, it's always and only been urine that could be utilized to evaluate drugs of abuse testing for federal employees. But in October, the SAMHSA and the Department of Health and Human Services believed that we'd reached the point in time that oral fluid would be a good alternative, with the caveat of understanding the windows of detection and the relevance of the substances, etc. Next slide. So this will apply to federal executive branch employees. They will be able to take a urine test or an oral fluid test when they're screened for employment. But it also opened the door to sensitive industry workers regulated by DOT, Nuclear Regulatory Commission, military, etc., to use this method. So there is evidence of some reliability. Next slide. And they've mentioned specifically in their in the updated regulations that because of advancements in oral fluid drug testing, accuracy is essentially equivalent to urine, again, noting the period of time for which drugs can be detected in that matrix. There's also a lower tampering risk. There's been a lot of time, effort, and investment in figuring out how to tamper or alter urine samples. So oral fluid's a little more difficult to tamper, especially when you're watching the patient give the sample. Reductions in biohazards, stable specimen materials, smaller specimens themselves have all evolved with new products that are on the market now. Next slide. ASAM also has supported the concept of using drug testing in clinical addiction medicine with oral fluids. They came out in this statement that I talked about earlier, this consensus statement, saying that it's absolutely appropriate for presumptive detection and addiction treatment settings. It's observed but unobtrusive. It requires less resources, including the need for a restroom and reduced tampering, as I've already mentioned. Next slide. The drawbacks that are pointed out by ASAM are there can be difficulty with sample collection due to patients that have dry mouth. If they've recently eaten or smoked, it can contaminate the sample, the saliva sample, or if they've recently consumed drugs. But that's primarily for quantitative levels. If they've recently consumed, it can really elevate the nanograms per milliliter, the strength of the sample. But that wouldn't apply with qualitative, obviously, because qualitative is just the presence or lack of the substance. They do recommend that if you utilize oral fluid testing, that you use the type that have absorbing pads versus what has traditionally been used is basically spitting into a test tube, oral expectorating. I don't know if you've ever had a patient do that, or with drugs of abuse or anything else. I used to do hormone testing on patients for a partner clinic, and patients, it would take a good 15 minutes to fill a half a tube of saliva, because it's hard to keep expectorating, keep spitting and keeping moisture in your mouth. So that can take a while. And so it's much more convenient to have an absorbing pad and the collection device. Next slide. So when selecting a device, if you would be interested or wanting to use oral fluid as a testing matrix, it's important to look for FDA approved devices and examine the CLIA complexity, either waived, moderate, or high complexity, and that's going to define where you can perform the test, or if it has to be performed in a central lab. And obviously that's to assure that there's quality and reliability in the results. If you ever want paid for it, CMS expects your devices to be FDA approved. And if you're ever working on a grant project, then the federal grantors, SAMHSA, HRSA, whoever, expect, unless you're participating in a trial or have explicit approval to use a non-FDA approved device, that your device is used will be FDA approved. So considering that, there are a number of tests on the market. There's a lot of tests on the market, frankly, that are qualitative point of care saliva tests. Most of them, however, are used forensically. Drug courts, police who pull people over, sometimes insurance companies will use that when they come out and do an exam for, say, life insurance. But there are far less that are approved that give you a qualitative result at the point of care without the need for an analyzer or equipment. And there's actually two. If you hit the next slide, they'll come up. Next slide. So there's two. These are the two that are FDA approved that give you qualitative results at the point of care, don't require a send out, don't require an analyzer. They're the oral tox, which is on the left, and OraTech, which is on the right. Next slide, please. So of these two, the OraTech was the first one FDA approved for a six panel drugs of abuse. And again, 2012, that was approved. The 6 drugs are methamphetamine, amphetamine, morphine, THC, PCP, and cocaine. And the cutoffs are listed here. If, you know, this kind of looks like a pregnancy test. You take the blue end off of the testing structure. You put, the patient puts the little absorbent white pad there. They brush each cheek in a circular motion for a few rotations, and then they place the white absorbent pad under their tongue, and the manufacturer says for about 40 seconds. And then if it's positive, you will not see a line in any of the spaces for the various drugs, but at the top are the control line. So you should always see control lines that cross that space. A negative would be lines in every single space, and a positive would be control lines in the top, but any absent line would mean that drug was detectable at the cutoff rate or above in that sample. Next slide. Oral tox was approved by the FDA for the 8-panel testing in 2018. And it has exactly the same cutoff limits, but there's an addition of oxycodone and methadone to their panel. And as you can see by the little picture, it's the same concept. The top line is the control line. The lines on the bottom are the actual test. And if there is a line that shows, that means the test is negative. An absence of a line for that particular screen would be a positive result. And there are additional drugs of abuse testing available for this model, but they haven't been FDA approved. Including are some very important ones for our situation of benzos and buprenorphine. So that's in the process of getting approved, but is not yet approved. The other nice thing about this particular qualitative test is, as the clinician or the treatment team, you can see the results immediately based on the qualitative or presumptive results. But you can use the same sample, the little sponge that was placed in the mouth before you stick it in this box. You can use that same sample and send it off to a lab for quantitative testing, which is convenient. The other test, you have to do the expectorant model in a different device with the OraTech to get the definitive results. Next slide. So both tests use immunochromatography assay, where the oral fluid that they've put in their mouth and has saturated the absorptive pad or the sponge migrates up the test strip, and as it passes over the film, if target drugs are present in that specimen above the cutoff range, it saturates binding sites that are coated on the particles, and a colored line will not appear. It will obstruct the color. It will not appear. A band that forms, if you see the line that forms, there is no drug, or drugs less than the cutoff are in that oral fluid sample. And then a band, as I mentioned, should always form in the control region. If it would not, then you don't have an adequate sample, and the test is inconclusive. Next slide. And this is just a visualization of how that testing mechanism works with the competitive immunochromatography. Next slide. So in consideration of needing to perhaps have some assistance in addition to bringing patients in for urine drug screenings, the concept of oral fluid looks promising. There are a number of drug addiction clinics across the country that do completely by distance all of their MAT treatment. North Carolina has a program that they use all online. They do saliva testing for their drug testing, but it's definitive testing. So they watch the patient put the product in their mouth, get the saliva sample, put it back in the container, seal up the envelope, and mail it to a central lab for testing. I didn't really find anybody that, at least that was obvious, that was doing qualitative testing on screen so you could see the results in real time. Again, presumptive, not definitive, but just to give some guidance similar to what we do when we do urine drug screens before patients see us in our addiction treatment clinics like we do at COPE, for example. But this is a statement from, or a determination position from Medicare. In West Virginia, our Medicare contractor who processes all of Medicare is Palmetto GPA. And this was put out in November of last year about what they cover for controlled substance monitoring and drug abuse testing. And they do include, even though the entire document talks about UDTs, which means urine drug testing, in the specimen type, they do point out specifically that urine or oral fluid is a preferred biological specimen for testing. So it is acceptable by CMS, Medicare, but as anybody that follows payer policies, if CMS doesn't approve of it, it's not going to happen by any other payer. So Medicare, and then of course Medicaid follows Medicare guidelines. So oral fluid is appropriate for a matrix to be paid. Next slide. The code, the CPT code for a presumptive test, a qualitative test for the ones that we just reviewed is 80305, and that was released in January. And just to let you know, right now, the reimbursement for West Virginia Medicaid fee-for-service is $11.34 for an 80305. Next slide. The big caveat right now in the world that we're living in by telecope, telehealth, telemedicine, whatever we're calling it, is that point of care testing, the 80305, is defined as when the beneficiary and the provider, the physician, are in the same location. So if we, patients, it doesn't say you can't do this, you can't have patients take these oral fluid tests by distance, but it would not be reimbursable at the current time because the two people, the provider and the beneficiary, have to be at the same location when the test is administered. And to date, the same location doesn't mean you can see them, doesn't mean that we're both engaged synchronously on a platform where we can exchange. It means physically in the same location. Next slide. So in short, there could be a role for oral fluid drug screening in currently the lockdown that we're in, the stay-at-home orders. Obviously, we can still bring patients in if we're very concerned, or if they're high risk, or if we have high suspicion. But there may be a role to decipher whether we have high suspicions for patients by using qualitative tests with oral fluid. They're reliable as a matrix. They are the most convenient way to test if we are going to do it randomly across distance through telemedicine. The central labs are still reimbursed for definitive testing, but as I mentioned, right now, point of care does not cross space. And there is still some room for drugs of abuse that we're particularly interested in that have not yet been FDA approved in these qualitative tests, but are in the process of getting approval right now. And that's the last slide other than the references. Has anybody used qualitative saliva test?
I know we've used it, not in this instance though, but just prior in our clinic for people who did not need the required like twice a month or monthly tests.
What was your experience with them?
Easy. Now, the test we use though, sometimes, it looks like a lollipop, right? And sometimes when they put it in their mouth, it would just disintegrate and fall apart. before it turned blue, the color came to give us to say that it has enough saliva on it. So that was the only problem. Most of the time it was fine.
Jeremy asked a question. Do I know the cost? Sheena, are you still on here? Was it $8? We didn't test out the oral tech, but the oral tox, I believe, is $8 a test. Is that right, Sheena?
Yes, it was. It was like $1 per drug, so it was $8 for the 8-panel drug screen.
Thank you so much, Tony, for that didactic. That was excellent. I wanted to ask everyone out there if there were any questions you had for Tony or in relation to that. We still have about half the session left too, so feel free to chime in with anything you'd like to discuss as well.
I did have a question for the group. Does anyone have their groups up and running over Zoom?
Yeah. Hey, Dina, it's good to see you. We've been, I'm not good with time frame during COVID. I feel like days and weeks are blending together. So I'm going to look at Douglas for confirmation, but we've been running groups, both med group and therapy group together for 3 weeks, maybe?
This is our 4th week.
Okay. Yeah. And it's gone surprisingly well. Again, I will let Douglas share his 2 cents. On my end, I think I was coming into it sort of already feeling some anxiety about it and almost like apologetic to the patients. Like, I'm so sorry I have to do this tele and there's so many hiccups. But the patients over and over have been incredibly grateful and gracious about it. They're just like, no, thank you for, making this as an option. Some of them were like, thanks for doing this so we don't have to come in. And some of them, I think, had an anxiety of when all this happens, because a lot of our patients just naturally worry something's going to happen to their medication. So this pandemic made them think, oh my gosh, am I not going to be able to get my medication? What's going to happen? And so they've been really gracious about just natural hiccups that occur, running them over Zoom. But it has gone way better than I think I thought it was going to, but that's also because technology is not my strong suit. Douglas, I don't know if you have any.
No, it has. It's gone surprisingly well. It was a lot of work to transition about 500 patients from in-person to virtual appointments in such a short amount of time, but we did that probably within just a few days to a week. A lot of people put in a lot of work to make that happen. But once we got that done and things up and running, it has went surprisingly well.
Good, because so far we are just doing individual, and we just got our platform last week to do Zoom groups. So we're thinking of starting that as soon as possible, because that would free up at least a lot of time.
Yeah, absolutely.
It's great.
If you guys need any help with that, just let me know. I'd be more than happy.
We do. I'll be calling you all.
Absolutely.
Heather, was there something you wanted to say?
Yeah, we did it at Camden also. We've done it for about 3 weeks, 4 weeks. I'm with you. I don't know, long time. They've done well with it. They enjoy it. And they've actually asked to have a second group where I just set up the platform with the case manager and she stays and they do their own thing. So it has increased their groupness and their contact with each other, and they kind of do their own little support group with each other, which is fabulous.
That is so cool. That also tells me what kind of environment, what kind of clinic, therapeutic atmosphere you guys have created down there, that they want more of your services. They want more of each other's group time. That says a lot. I think that's so cool.
Yeah, we were pretty excited that they wanted to do that, and they keep doing it, because we thought, well, we'll just do it once and see how it goes. But they've done it for 3 weeks now, so I think it's going to stick. So that's great.
That's awesome.
Any other comments, questions, concerns, COVID topics?
I wonder if I can ask about urine dipsticks. Hello?
Hi.
Oh, okay. I don't know if you can hear me. So, I mean, I understand that they fall under the category of qualitative or presumptive testing. But my understanding is that they're a pretty good quality now. And in terms of costs and timeliness, the use of urine dipsticks rather than lab assays is a pretty good practice most of the time. And I've read the ASAM white paper on this, and the need to send urine out to labs is really something that's under a minority of situations that is really necessary. And most of the time in most clinical practices is when the patient absolutely disagrees with the finding on the dipstick. One, I'm wondering whether there's evidence that yes, the urine dipsticks are pretty good, not a match for lab assays. And two, whether there's a source where you know, the better instruments can be found and what their costs are. And then a third part of this is it advisable to use urine dipsticks that include alcohol, or is it better to use urine dipsticks that don't include alcohol and then couple that with a breathalyzer if there's a suspicion for alcohol? So 3 parts.
All good questions. Tony or Dr. Hirschler, I don't know if either of you want to speak to that.
I can speak to the first part for sure. Yeah, absolutely. That in the ASAM white paper, they talk explicitly about that, about being effective in managing costs in treatment centers. And I know even at the state level, there's been a lot of concern about excessive testing, and we're spending too much money on this. And I get that. And, they talk about the irresponsibility of, doing presumptive and then qualitative or, definitive on every single patient. So yes, I mean, I think that is not only recommended, but the right thing to do. I think they're of high quality enough, coupled obviously with, presumptive testing doesn't replace clinical judgment. And, as fast as we have a strip to measure that, there are other analogs that are being sold on the market that we don't even know how to test yet. So clinical judgment takes priority, but I just would say that they should be FDA approved if we want to make sure they're quality, and the costs are much more effective. And in the context of what we were talking about today, it was, difficult. Like, you could do urine dips by distance, but will you know if that sample is really that patient? So I would think, if we were still in the world of seeing patients in person, I think that would be the modality that would be most advisable, because you can also send off the extra urine for the definitive test if you need it. And I know, here we don't, we do dips on a lot of people and not send, if they're negative, we don't send them off for definitive testing. And what was the third part of your question?
Well, the second part was whether a good source to list, manufacturers and what the prices are. And then the other one would be strategically whether to do the alcohol by urine dipstick or to get the dipsticks without alcohol and use a breathalyzer for alcohol.
I think we used to many moons ago use a breathalyzer, and we found it was not nearly as effective as having a separate urine screen for it.
I see. So you would recommend that providers generally use dipsticks that have a panel that includes alcohol and then skip the breathalyzer component?
Yeah, I think also and Tony, correct me if I'm wrong, the dipstick can help trace much farther back alcohol use. Is that right? So it wouldn't necessarily show up on a breathalyzer, but it would show up on a
what the ETG, ETS, which is we send off. Our dips don't have alcohol in the dips. At least the ones we're using in Morgantown don't have the dips. We send randomly people to do ETG, ETS send-offs.
The reason I'm asking is because I've heard mixed about this, that they say, yes, there are dipsticks that have alcohol, you can purchase those, but the breathalyzer is more sensitive or somehow better. But But you make a good point about the time factor. So I guess I have to look up different sources for dipsticks. But I just want to underscore as part of this discussion, not something that was brought up, but in the ASAM white paper, and it very much resonated with what I see in terms of what goes on in various clinics. And that is, patients are aware that if you're ordering multiple tests that you don't really need, if you're doing presumptive testing and you're following up with confirmatory testing without a clear indication, patients know that you're gaming the system and just trying to rev up revenue. Mm-hmm. And that undermines their trust and promotes dissocial behavior among addicts, because they think everybody does it, so we'll break the rules too. And so as long as providers are listening, I just figured I'd mention that, because there are consequences to it other than just costs. You're actually undermining ethics and quality of care by doing that.
I can make a comment. You know, probably the most important testing that we do is in regard to safety of the patient and overdose risk. And so testing things like fentanyl or carfentanil and sedatives like alcohol and benzodiazepines. And so any test that doesn't include that is kind of going to put the patient at risk. So I think the send-outs that we do to confirm catch some things that the point of care testing misses.
Yeah, but then you wouldn't be duplicating on the one hand, and the fentanyl thing, I mean, that's usually a component of other agents, and it's very short acting. So clinically, you know if somebody's in trouble with opioid withdrawal, that you don't need to send to the lab at that point. The speaker can maybe address this. The benzos are a particular indication, but what happens a lot is people get in the urine drug dipsticks, and then they're sending out to the labs with or without a suspicion of benzos.
I can tell you, gosh, from our clinic, what we're seeing a lot is people are telling us, I'm not using opioids, I'm using meth. And when we send away from confirmation, it's coming back with fentanyl. So they're using substances that aren't, you know, they're telling us they're using meth or cocaine, and those confirmation tests are showing to us what they're using. And then that's a great safety conversation for us to be able to have with the patients.
But are you getting confirmation without, in other words, you're getting negative dipsticks and then getting a positive confirmation?
Yeah, the drug screens that we have don't test for fentanyl, so we have to send them away. Did I answer that correctly?
I don't know that clinically this is really, I mean, the speaker can comment on this, because I don't think clinically that's really necessary. I think if you're sending away to the lab and getting a confirmatory about fentanyl and the patient's in front of you, you clinically have the information that you need without that lab result.
Well, the other value that sending away to get quantitative levels is to track over time, because, you know, to know the levels and to be able to do a creatinine adjustment, to know that, like, they, you know, they might say that, no, I just used last week or 3 days ago when I saw you, but we do serial testing for levels. And I think that's what Katie's talking about. Like, so someone's, you know, said that they might have been honest and said, yes, I did meth, but there are so many things that are cut with other things that we kind of just happen to find that they're cut with central nervous system depressants that make us more worried about the risk to the patient.
Well, okay, well, I mean, we'll leave it there. It just seems that the frequency of use doesn't match that level of concern. It seems that there's overuse, and ASAM has taken a pretty clear position on that.
Dina, was there something you wanted to say as well?
No, I was just saying, I agree with Katie, because there are many times when patients think they're taking a certain substance, and when you go in and check and send it back, and they're not. So we find the confirmation test very important. The immediate one I find is important. Yeah, you're right in terms of benzodiazepines. Also, as you know, in our labs, you don't show up the opioids, right? Just the opiates, right? And the UES is only good for cocaine, because you know you can't really fake that. But I mean, so we find it pretty helpful. But we do get your point. It's very important to not misuse the system and overcharge patients unnecessarily. So that's a really good point.
Mm-hmm.
Awesome. Were there any other questions or comments?
I would just, oh, I'm sorry. I would add to
Sorry about that. Go ahead.
the lab confirmations. We use when we do our confirmations, they also include norbuprenorphine in them, so we can tell that the client's actually taking the bupe. Plus, we have a naloxone detector on it too, so we can tell if they've traded it for Subutex too. So those are two more benefits you can get from a lab confirmation that I don't think is available in a dip test.
Right, that's a good point, because those can be dip test and even oral fluid. If you just put the Suboxone in your mouth and took the oral swab, or it's going to show positive for that, but the metabolites will only show in the urine.
Tony, I was just going to say there was that resource you had sent to me. Did you want to mention something a little bit about that?
Yeah, and she can send it out with the PowerPoint slides if you're interested, but and I referenced it a couple times, and I think one of the questions is referencing the ASAM white paper or consensus paper on the use of drug testing in clinical addiction medicine. Many of you might have already read or have referred to it, but I found it very informative about different types of testing matrices and how to use drug testing in general, presumptive versus definitive. So it's a nice resource.
Awesome, thank you. And as you said, I'll make sure to attach that in the recap email with your PowerPoint. We have about 14 minutes left. Anyone want to chat about anything or bring anything up? I don't want to keep you all here, but.
Great presentation, Tony. Thank you.
Yeah, thank you so much, Tony.
Thank you.
Excellent. But I will make sure to get that recap out with the resource Tony kindly provided for us, and attach her didactic as well. Thank you all so much for joining. I do have one quick announcement, and that is our next session is going to be on May 11th, and Phil West is providing our didactic on building patient trust. So keep an eye out for that. We do still encourage everyone to submit some cases. Of course, prioritize everything that you need to, but we'd love to have a case and have that presentation and keep that going on as usual too. So thank you all so much. Stay safe and have a great rest of your week. Thanks, guys.
Thanks, Mitra.
Thank you.